Hello, my name is Gurjit.
And my name is Kimiya, and we will be presenting our case study on hypertension known as the silent killer. So we have here an 82-year-old Hispanic female who has had difficulty controlling her hypertension lately. She has a BMI of 45.2 and is displaying a recent persistent increase in blood pressure readings. She verbalizes having a severe headache, and her blood pressure reading upon admission was 210 over 116. Health history: hypertension for 11 years, chronic kidney disease stage 4, diabetes mellitus, chronic low back pain. Objective assessment includes her being overweight, tachypnea, pallor, cap refill 4 seconds, and immobile. Subjective: reports severe headache, states she does not smoke. Her diagnosis is risk for decreased cardiac output related to increased vascular resistance. Vitals upon admission: 210 over 116 was her blood pressure, heart rate of 88, respiratory rate of 22, and temperature of 37 degrees Celsius. Labs: glomerular filtration rate of 27 milliliters per minute, which is quite low, a blood urea nitrogen of 30 milligrams per deciliter, creatinine 50, hemoglobin 9, hematocrit 39%, electrolytes within range: sodium 135, potassium 4.2, calcium 8.9, phosphorus 3.7. She's currently on hydrochlorothiazide 50 milligrams twice per day, lisinopril 20 milligrams once daily, metformin 500 milligrams once daily, glipizide 10 milligrams once daily, atorvastatin 20 milligrams once daily, and acetaminophen 325 milligrams as needed. Risk factors for this female includes her falling into the obese category, having a BMI of 45.2. Patient's diet is poor and includes too much salt. She has diabetes mellitus, and she lives a sedentary lifestyle. There is no regular physical activity, being that she is immobile. She is of Hispanic ethnicity and an older adult, being 82 years of age. These are all risk factors for developing hypertension. Others include being of African American descent, having a low HDL, a high LDL, increased triglycerides, and smoking. So what is hypertension? It is the high force pushing against the walls of the arteries. Hypertension is a sustained elevation of blood pressure, a sustained systolic blood pressure over 140, and a sustained diastolic over 90. There are two types of primary hypertension, one being primary hypertension and the second being secondary hypertension. Primary hypertension accounts for 95% of all cases. It is caused solely by risk factors and not an existing illness. The more risk factors you have, the more chances of developing primary hypertension. Secondary hypertension is when a specific drug or disease increases the susceptibility. For example, this patient has chronic kidney disease, a contributing factor to secondary hypertension. Signs and symptoms of hypertension. It is known as the silent killer because patients are frequently asymptomatic until severe target organ damage has already occurred. Generalized symptoms include fatigue, reduced activity tolerance, dizziness, palpitations, angina, dyspnea. If left untreated, untreated hypertension can lead to strokes and heart attack. So the pathophysiology of hypertension, it affects many major organs in your body, including the heart, brain, and kidneys. It also affects the eyes. Atherosclerosis forms due to high blood pressure hardening and thickening the arteries, which also leads to heart attacks and strokes. Examples of cerebrovascular diseases from hypertension include aneurysm, because the increased blood pressure can cause your blood vessels to weaken and bulge, forming an aneurysm. If this ruptures, it is life-threatening. Examples of nephrosclerosis includes weakened and narrowed blood vessels in your kidneys, and this is because when the force of blood flow is very high, the blood vessels in your kidneys stretch, so blood flows more easily. Eventually, the stretching will scar and weaken the blood vessels in the kidneys. If the kidney blood vessels are damaged, they may stop removing wastes and extra fluids from the body. Extra fluid in the blood vessels may raise blood pressure even more, creating a dangerous and repetitive cycle. In most people with hypertension, increased total peripheral resistance is what causes the person to have chronic hypertension. As people age, the arteries harden, increasing resistance, which is why hypertension is more prevalent in older individuals. So factors involved in high blood pressures are kidney and salt imbalances, the renin-angiotensin-aldosterone system, excessive sympathetic activity, and a person's genetic disposition. So what happens in the kidney and salt imbalance is that there are 10 genes that have been identified that can mutate. When these genes mutate, they alter the handling of salt in the kidneys, which increases intravascular volume, thus increasing your blood pressure. There are arterial baroreceptors that reset to higher pressures in hypertensive patients, meaning once someone has high blood pressure, the receptors can detect if the blood pressure comes down and then will activate the sympathetic nervous system to increase the blood pressure, keeping the hypertension going. Stress can also increase the sympathetic response, which is why it is thought that people from a lower socioeconomic status have more prevalence of high blood pressure. Lastly, the third factor that influences hypertension is the renin-angiotensin system. When circulating renin increases, this causes angiotensinogen to be converted to angiotensin 1, which is converted to angiotensin 2 by the ACE enzyme, angiotensin converting enzyme. Angiotensin 2 is a potent vasoconstrictor which raises the blood pressure, and it causes the adrenal glands to release aldosterone, which stimulates the kidneys to reabsorb salt and water, leading again to higher intravascular volume and higher blood pressure. So diagnostic testing for hypertension includes blood testing, echocardiogram scans, a 24-hour blood pressure monitoring, and a 24-hour urine test. The blood test is to check for elevated cholesterol and any other conditions such as kidney disease or diabetes. The echocardiogram scan provides a detailed view of how the structures in the heart are working and can reveal if there is any left ventricular hypertrophy or problems with your heart valves. A 24-hour blood pressure monitoring is useful to monitor blood pressure at regular intervals at a 24-hour period to get a clear picture of how your blood changes throughout the day. It is useful for administering drug therapy. Lastly, a 24-hour urine test is useful for detecting whether there's any protein in the urine, kidney disease. If there is protein in the urine, kidney disease may be present, which in this case there is for our 82-year-old Hispanic female with CKD stage 4. A urine test is also able to detect if there's sugar in the urine, an indication for diabetes. Again, she is indicated for diabetes mellitus. Some physicians will require a 24-hour urine test to detect how much salt you are eating. So drug therapy for hypertension. Firstly, diuretics are used. They are the first choice for management, which all inhibit reabsorption of sodium. Examples include hydrochlorothiazide and furosemide. Next is calcium channel blockers, which interfere with the influx of calcium, resulting in vasodilation. Example includes veramipil. ACE inhibitors block the conversion of angiotensin 1 to angiotensin 2. An example of an ACE inhibitor is lisinopril. And lastly, angiotensin receptor blockers bind to angiotensin 2 receptor sites and compete with them. An example is losartan. Other hypertensives, when these drugs fail, are aldosterone receptor antagonists, beta blockers, and renin inhibitors. A nursing safety precaution is to make sure to monitor for potassium levels and assess for irregular pulses, which may indicate decreased potassium. And monitoring this will prevent electrolyte imbalance, which can cause life threatening cardiac dysrhythmias.
Okay, so for our patient teaching, teach patient, family member, or caregiver how to properly use the blood pressure monitor, which includes how to position the cuff, how to inflate using the balloon, and how to interpret the results. And our second teaching includes dietary approaches. And according to the 2013 ACA AHA guidelines on lifestyles management to reduce cardiovascular risk, they came up with dietary approaches to stop hypertension, also known as DASH, and this included to consume more vegetables, fruits, and whole grains, consume low fat dairy products, poultry, fish, non tropical vegetable oils, and nuts. They also recommend lowering sodium to no more than 2,400 mg, preferably no more than around 1,500 mg. And they also suggest to limit sweets, sugar, and red meats and engage in aerobic activities 3 to 4 times weekly, lasting 40 minutes or longer. And some examples of cardio exercises, aerobic cardio, aerobic exercises, cardio machine, running, swimming, walking, hiking, aerobics class, dancing, cross country, skiing, and kickboxing. So for our nursing diagnosis, the first one that we came up with is a decreased cardiac output related to increased vesicular resistance and altered contractility as evidenced by abnormal skin color, which is also known as stenosis, decrease in peripheral pulses, dyspnea, immobility, and prolonged capillary refill. And the second nursing diagnosis that we came up was uh, activity intolerance related to sedentary lifestyle as evidenced by abnormal heart rate and or blood pressure, which which is altered because of activity levels. And our third nursing diagnosis that we came up with was imbalanced nutrition, basically meaning more than the body requires, related to excessive intake in relation to metabolic need, as evidenced by a BMI of 45.2. Okay, so for our short-term goal for decreased cardiac output, we have the goal is to maintain optimal cardiac output as evidenced by vital signs being within reference range and blood pressure being stable by end of shift. And this also falls in within the SMART category, meaning it's specific, it's measurable, it's attainable, and it's timely. And our first intervention is we apply graduated compression stockings as ordered by the physician. So you need a physician's order for this. You ensure proper fit and remove stockings at least twice a day. And before reapplying, assess the condition of the extremities frequently. The rationale behind this is the graduated compression stockings help promote venomous return and reduce the risk for deep vein thrombosis, also known as DVT, in hospitalized clients. Our second short-term intervention is to place client in semi-Fowler's or high Fowler's position with legs down or in a position of comfort. The rationale behind this is elevating the head of the bed and legs in down position may decrease the work of breathing and may also decrease venomous return and preload. Our third short-term nursing intervention is we provide a restful environment by minimizing controllable stressors and unnecessary disturbances. The rationale behind this is reducing stressors, decrease cardiac workload, and oxygen demand. Our fourth intervention is closely monitor fluid intake, including intravenous lines, maintain fluid restriction if ordered. Our rationale behind this one is in clients with decreased cardiac output, poorly functioning ventricles may not tolerate increased fluid volumes. For our long-term goal, we picked have the patient walk 21 to 50 feet by themselves or with little help by discharge. And again, this also fits the SMART category, meaning it's specific, it's measurable, it's attainable, and it's timely. Our first intervention for this is we assess the client daily for appropriateness of activity and bed rest orders. Mobilize the client as soon as possible. The rationale behind this is that mobilization is a simple and cost-effective method of maintaining stable cardiovascular parameters, basically stable vital signs, countering orthostatic intolerance, and reducing the risk of secondary problems in clients during long-term immobilization. Our second long-term intervention is gradually increase activity, allowing the client to assist with positioning, transferring, and self-care as able. The rationale behind this is a reduction in plasma volume associated with bed rest impacts the physiological responses of autonomic control of circulation. Our third intervention is we perform range of motion exercises if the client is unable to tolerate activity or if they are mostly immobile, which the client is. Gradually increase duration and frequency and then intensity to sitting and then standing. Take precautions such as dangling the client and applying leg compression stockings before the client stands up. The rationale behind this is we exercise maintains muscle strength, joint range of motion, and exercise tolerance. Physical and inactive patients need to improve functional capacity through repetitive exercises over a long period of time. Gradual progression of the activity prevents overexertion. Our fourth intervention is we monitor and record the client's ability to tolerate activity. We note the pulse rate, blood pressure, respiratory pattern, and skin color before, during, and after activity. The rationale behind this is unstable. The results may indicate overexertion, and the client should return to bed immediately if this happens. Here are our references, and that's it. Thank you, guys.